Class, this is the HEENT and Integumentary Exam 1 Student Version PowerPoint. We're going to touch on the objectives, which you will see in your PowerPoint. For the head, we want to make sure we know how to assess it. How do you know a patient has a specific type of headache? You must ask them, right? It's very straightforward, you guys. Frequency, prevention, and treatment for a cluster, attention, and a migraine. And if you recall from class, we discussed that generally prevention and treatment are all the same. For your eyes, assessment. How do you use a Snellen test? How do you do PERLA? What does PERLA mean? What are your cardinal fields of gaze? Cranial nerves 2, 3, and 6, your normal and abnormal findings for assessing the eyes, safety risks for decreased vision. These are all things you've learned from 5th semester that you need to bring back to the forefront of your mind now, because we are going to have questions on your exam about this, which only makes sense, right? Because we need to build on that information. For glaucoma, what's the difference between closed angle and open angle? Post-op surgery considerations. We discussed that glaucoma, cataracts, and middle ear surgery all have the same considerations, which is, that's right, increased IOP, intraocular pressure. So you need to review those things. Macular degeneration, what's the difference between wet versus dry? Your pathophysiology, what does it actually look like? What is the treatment? Cataracts, post-op expectations, once again, slightly different from glaucoma, right? Because they get it for a different reason. What are your risk factors? And how do we prevent cataracts? How do we administer eye drops? And how do we make sure that our patient is well cared for post-op surgery? Next slide. For the ears, we have the Weber test, the cranial nerves, normal abnormal findings, safety risks for decreased hearing. Once again, 5th semester, okay guys? Go back, remember, why did I use the Weber test? What did I find? What was normal? What's abnormal? Conductive versus sensory neural hearing loss. What causes these different types of hearing loss and how do your patients prevent them? What safety considerations do you have for vertigo? How do we prevent it? How do we treat it? Tinnitus, safety considerations, how to assess it? Otitis media, safety considerations, what is it? Otosclerosis, what is it and is it normal in older adults? And what can cause this? Once again, how do we administer eardrops for adults and pediatrics? What are the ways to prevent hearing loss? Both kinds. Name a few of the ototoxic drugs and what you do if your patient is on them. And then once again, patient education for post-op middle ear surgery. Next slide. We need to touch on the nose and throat, even though we get into more depth when we hit respiratory and the different cancers as we move forward. But what is a nasal fracture? How do you know your patient has had one? And how do you know that a patient needs extra help after a nose injury? So we want to look at the color of the fluid coming out of the nose and what that indicates. And as we move forward, I'll go through that with you. For the throat, how do you know a patient is having difficulty swallowing? Well, let's think back to 5th semester. If your patient is coughing, if your patient tries to take a drink and they start coughing, they keep clearing their throat. These are all indicators to you that there's a potential that your patient has dysphagia. So what does a nurse do to ensure safety for the patient when they have this problem? And how does a nurse evaluate that a patient needs further assessment after they do the swallow screen? We'll touch on this as well. For integumentary, once again, normal, abnormal findings. Is pink, warm, and dry normal? Yes, you guys know that. Is blue, diaphoretic, red, erythema, are these normal findings for integumentary? And the answer is no. So let's connect them to different disease processes now. You have different drainages like sanguineous, serosanguineous, slough, purulent drainage, and eschar. You need to understand, what does it mean if my patient has sanguineous drainage? What does it mean if my patient has purulent drainage? What do I do if my patient has these drainages? What is xerosis? What is psoriasis? How do we treat it? What is eczema? How do I treat it? Herpes zoster, once again, what is it? How do I treat it? You need to know the difference between a basal versus squamous cell carcinoma. What do they look like? How are they treated? Cellulitis, what is it? How do you treat it? Pressure ulcers, back to 5th semester, stage 1, 2, 3, 4, and unstageable, and your deep tissue injuries. How do we know our patient has it? How do we prevent it? And what do we do to take care of it? Patient education. Who's at risk for skin cancer? Sunburn prevention. Be specific. You want to be able to educate your patients on how to prevent getting a sunburn. Next slide. So how do you know a patient has a specific type of headache? You ask them. How do you assess head pain? On a scale of 0 to 10, sir, where does it hurt? How much does it hurt? Are there any increasing, like PQRST, right guys? So extra symptoms that go with it. Did something occur that caused this headache? You want to be able to assess where it's happening, what could be causing it, how long it's been going on. You want to be able to assess how bad is the pain, is it stopping them from doing daily activities, that sort of thing. What is the most common type? Tension headache, very good. And tension headache, as you can see, they have that band around their head. It's a pressure headache, right? What is the least common type? You have your cluster, then your migraine. Your migraine is 11% of population. Cluster is actually 0.4% of the population. So how do our patients prevent these headaches? They've got to decrease their stress. They've got to make sure that they can control, if they can control their environment, we want to make sure that they do that. So decrease the lighting. We don't want it to be super bright. We want them to control how loud it is in their setting, because that can trigger a headache, right? So then we have our primary and our secondary causes. A primary just means the headache occurs, and usually it's either light, stress, or something that they've eaten that can cause this headache, but generally it just means that the headache happens. Nothing actually caused the headache. Then you have your secondary headache where something has caused it. A head injury, a stroke, a brain bleed, something has come before the headache, and that makes it a secondary headache. When your patients want to prevent the headaches, they can determine what's causing them by kind of ruling out what's going on. But lots of times we say no artificial sweeteners, decrease your stress, and change your environment. We can also help our patients to treat this problem with medications like our sumatriptan, our triptan medications. Excedrin with caffeine helps migraines as well. Next slide. Okay, so I'm not going to talk too much about this. You guys need to be able to answer these questions. How do you assess a patient using the Snellen chart? How would you walk them through it? Stand here, look at this, answer these questions. What cranial nerve are you assessing when you do Snellen? How do you assess cranial nerve 3? What does it mean when you say pupils equal, round, reactive to light, and accommodation? And what cranial nerve do the 6 cardinal fields of gaze assess? This is all reviewed from 5th semester. Next slide. Glaucoma. Talked about this in class, so let's touch on some of the big stuff again. What is the difference between closed angled and open angled? Open angled is caused by pressure, so it's closed angled, sorry. Closed angled is going to develop quickly. It's going to be an emergency. There's going to be an injury, a blockage of some sort, and they will have severe sudden eye pain. Open angle is going to be a lot slower, and they don't necessarily have noticeable symptoms. Maybe mild eye pain, but generally it happens over time. It can be with age. After your patient has surgery for their glaucoma, what do they need to be considerate of? Think back to what we talked about just a few minutes ago. We don't want them to increase their intraocular pressure. So if you look at my pictures, you'll see laying flat can increase, straining or bearing down can increase it, and bending over can increase intraocular pressure. So anything that can do that, we want to make sure that you guys are familiar with so that you can educate your patient about that as well. Next slide. Whoops, sorry. Oh, crap. Okay, we're going to move on to cataracts. So what are the risk factors for cataracts? UV rays. They need to wear sunglasses. That's how we can prevent cataracts. Wear sunglasses. Other risk factors include eye injuries, being diabetic, smoking, autoimmune disease. These are all things that can lead a person to getting cataracts. How do I know my patient has cataracts upon assessment? They're going to have blurred vision. They're going to have those cloudy, foggy eyes. They might have mild pain. What should your patient be aware of after they've had cataract surgery? That mild pain and using night lights. Oh, I'm so sorry. Okay, I'm back. Your patient should be aware that if they have changes in their vision, that it's an emergency and they need to go talk to their doctor. That is not a normal finding or an expected finding after they have surgery. When should your patient call the doctor? When they have changes in vision. Persistent pain, despite the use of over-the-counter pain relievers, increased eye redness, nausea, vomiting, excessiveness of that, that's definitely another reason. So how will the patient care for themselves? Well, patients are going to have trouble caring for themselves for the first couple days because it's post-op, right? And their eyes are for sight. So we have to worry about decreasing their risk for injury, meaning we need to increase their safety. So we need to ask family to help. We need to see if we have the ability to get them extra help. Remember, no bending, no housework. We want to make sure that they take their medications correctly. So the drops go into the conjunctiva, they pull down the bottom lid, they do not rub their eye, and the medication that will be given is going to help to reduce the IOP. So for glaucoma, latanoprost is a great medication for that. Cataracts, they probably use the same medication. Okay, next slide. When we assess the ears, we need to know the difference between normal Weber results, conductive hearing loss, where it's going to lateralize to the affected ear, meaning that the sound is going to lateralize where we have a problem. The sensory neural hearing loss is going to go to the unaffected ear, so it's away from the problem ear. And then mixed hearing loss, it's going to be the unaffected as well. But what are some safety risks for a patient with decreased hearing? If your patient can't hear, can they hear the fire alarm going off? Can they hear someone yelling for help? Can they hear a bus coming if they're going to cross the street? Maybe they're blind too. Besides the point, you want to make sure you understand some of the safety risks, okay? What is the proper way to administer eardrops to an adult patient? Pull the ear back and up for our older children and adults, and pull the ear down and back for infants and children below 3 years. What cranial nerve are you assessing with the Weber test? That's going to be cranial nerve 8. And what does the Weber test look like? You have your Weber and you have your Rhine. So you guys want to go back to 5th semester and refer back to what these two tests are going to look for. What type of hearing loss would your patient have if the sound only lateralized to the unaffected ear? Sensory neural, very good. Old people, we have to remember, they have hardened earwax due to the atrophied glands, which puts them at a higher risk for impaction. And if they have impaction on a Weber test, where would you expect it to lateralize to? The affected ear, conductive hearing loss because of impacted earwax. Good job, guys. So if it lateralizes to one side with a Weber test, you know that it's going to be an abnormal finding. Okay, next slide. Conductive versus sensory neural hearing loss. What causes conductive hearing loss? Well, when you think of conductive, it is sound waves. So we have to think of things that are going to block the sound waves from making it to our eardrum. So having a ruptured eardrum will do it. Impacted earwax, foreign objects, allergies, fluid, anything that's going to block the sound from getting through is going to cause conductive hearing loss. What causes sensory neural hearing loss? This is going to be aging. This is where the nerves are going to change. So loud noises that affect the nerves. If your patient shoots a gun and isn't wearing protection, is your patient going to concerts or blasting their music too loud for a long enough period of time, they can actually get sensory neural hearing loss. Blast, explosion, tumors, medications that are going to affect the nerves is ototoxicity, like your NSAIDs or your aspirin or different antibiotics. your patient has inflammation, is that going to stop the sound from coming through? Yes. If your patient has otosclerosis, which we talked about in class, otosclerosis is hardening of the ear, and it's going to cause a blockage. And if that happens, is that a conductive or sensory neural? That is conductive. That is correct. Very good. If we have a nerve problem like ototoxicity, loud noises, aging, we're going to have sensory neural hearing loss. How do we teach our patients to prevent hearing loss? Well, that's an easy one, right, guys? Protection. Use protection. If you're going to be around loud noises that have the potential for hurting your ears, you must wear protection. You need to decrease your ototoxic medications or stop taking them if that is the cause. So the first question we have to ask is, what is causing the hearing loss, or what could cause hearing loss? And then we can teach our patients to prevent hearing loss based on that information. If your patient is going to be given an antibiotic that is ototoxic, what must the nurse check prior to giving this medication? How do I know that my patient doesn't have too much of a drug in their system? Gotta check that peak and trough, right? All right, next slide. So we have tinnitus, otitis media, and vertigo. So how does a nurse assess a patient for tinnitus? We ask them, right? Your patient is going to say, I have ringing, I am depressed, I have buzzing in my ear, I am inattentive because I'm too busy focusing on the sounds in my ears, I'm avoiding conversations. What does the patient need to do to help support this assessment? They need to keep a diary to tell you when they're hearing the sounds. They need to be able to identify what the sounds are and what the triggers are and how frequently they have them. Then we can look at this information to determine, okay, this is what's going on and this is what we need to do. The biggest concern for a patient with any of these, with tinnitus or vertigo, is going to be safety. I'm sorry, scratch that, I apologize. The priority for your patient with tinnitus is going to be isolation, depression, and frustration. Those three things are going to occur with tinnitus. If a patient is showing signs and symptoms of otitis media, is this a priority concern? No. Are they going to be pulling on their ear? Yes. Is there irritation, possibly an infection? Yes. But is this a big concern compared to somebody else who might have another problem like vertigo? Is vertigo a problem? Yes. Why is vertigo a problem? Can your patient fall? Can your patient injure themselves? And the answer is yes, okay? So we're going to treat otitis media with antibiotics. Let's move on to vertigo. Sorry, I'm jumping all around on this slide. I'm trying to look at my pictures and it's causing me to go all over. So let's go back here. How do we treat vertigo in our patients, and why do we need to treat it? They are at a risk for injury. We have multiple medications that they can take. They have meclizine, which is fantastic. Dramamine is the motion sickness medication you may take for boat sickness. What should patients do to prevent vertigo episodes? Make sure that they space out their water. Make sure that they are looking at their salt intake. If they decrease their salt intake and they're spacing out their water appropriately, should help to keep the water, the crystals inside of the ear and the equilibrium at an appropriate place. What medications are used to treat this problem? Well, I just said it, so you tell me. Meclizine. Is your patient going to be nauseous if they have vertigo? Yes. So what's another medication? Yes, Zofran. Very good. So safety for this patient, fall precautions, change position slowly, space out your fluids, take meclizine or Zofran, right? Good job. All right, so this page, I know it's a little strange, but I just want to touch on these things because they are on the exam and it's content that you've probably already heard, but I just want to touch on. So let's do a quick one on this. A nasal fracture. Clear fluid coming from the nose means what? Cerebrospinal fluid. That is not a good thing. That means that your patient needs attention now. If your patient has yellowy green clear fluid running out of their nose, yes, chances are it could be allergies, or it could be rhinitis, or it could be a cold. There's a lot of other things that it could be. But if there's clear fluid coming from the nose, especially after a traumatic event, we need to test it for CSF. Now, when we think about dysphagia, how do you know a patient is having difficulty swallowing? Talked about it a little earlier, so just think about it for a second. You assess them, right? Maybe they cough after they swallow. Maybe they keep clearing their throat. Maybe they're constantly trying to, maybe they are trying to swallow and they can't. You've ever seen them do that? If they take a pill and they keep swallowing and they're not able to, it's a sign of dysphagia. So what do we do to ensure the safety for the patient when they have this problem? We need to do a swallow screen. The nurse needs to assess it first before we ask speech therapy to come and assess it. How does a nurse evaluate that a patient needs further assessment after a swallow screen? If your patient coughs during an assessment for a swallow screen, what do you think the next thing should be? Okay, so your patient just indicated to you that yes, indeed, they have dysphagia. They are struggling to swallow appropriately. If that's the case and they have been eating already, what should you assess? Yes, their lungs. Because what if they aspirated prior to your assessment? We must make sure that the lungs are clear to ensure that they haven't aspirated. If they have aspirated, they can end up with pneumonia. Aspiration, pneumonia. So that's all you guys need to kind of worry about for your nasal fracture dysphagia. Like I said, it's very minimal right now, but just be familiar with those concepts in that manner. All right, let's look at skin. How do we assess the skin? This is back to 5th semester, right? A, B, C, D, E, asymmetry, border, color, diameter. Is it evolving? This is a difference between a normal bump or mole versus an unnormal bump or mole. Your borders are going to be ragged. They're not going to be differentiated. They're going to be undifferentiated, meaning they're not clear borders, okay? Their color is going to have multiple colors. There's not going to be one color. And there might be lighter or darker colors or different shades of different colors, purples, reds, blues. If the diameter is greater than 1/4 of an inch, then you are looking at a potential melanoma. You want to be able to recognize normal and abnormal findings for lesions and moles. And this is going to be the way you do that. A, B, C, D, E. You need to be familiar with that. When you assess the skin, how do you teach your patients to look at their skin? You want to say, okay, what are the normal findings and what are the abnormal findings? Is white plaque on your arm a normal finding? No. What might that be? Psoriasis, very good. If your patient has dry skin or xerosis, if it's dry, itchy skin, is that a normal finding? No, that's correct. Okay, so just want to make sure you guys are familiar with some of the basics for this, okay? How do you teach your patient to avoid the sun and getting a sunburn? Now, this is a 5th semester, so let's go through this. We've got sunscreen. We have protect your eyes and wear sunglasses with UV protection. Find a shady spot. Reduce your time in the sun. Avoid the sun between 10 a.m. and 2 p.m. Use a broad spectrum sunscreen all year round. Use an SPF of 30 or higher. Wear hats, protective clothing. Cover it. Cover your body. Okay? Reapply your sunscreen every 2 hours and after you swim because you'll wash it off, even if it says it's waterproof. Just saying. Okay? If you come over here to the right-hand corner, you want to be able to recognize the different exudates, including eschar. So you need to make sure you understand that eschar and slough are types of necrotic tissue. Is this okay? The answer is yes. Eschar is leathery, it's black, it's hard, but it's considered nature's Band-Aid. This is a good thing. Eschar is okay. Eventually, we keep it there, we put some betadine on it, and then it falls off, and hopefully we have new skin underneath. If your patient has slough, what do we have to do with it? Yes, we're going to have to debride. So you need to make sure you're familiar with the right steps for treating the different, treating your patient based on the different exudates that they have. What do you need to do if your patient has serous? Do we need to do anything if they have a serous exudate? No, that's correct. If it's purulent, what might that indicate? An infection. Very good. Okay, so let's go to the next slide. We're almost done here. Let's look at the top right. So you need to be able to identify the difference between a basal cell carcinoma and a squamous cell. Your basal cell are going to have red papules. They're going to have that waxy border and a crater center, okay? What education do we need to give our patients about a melanoma? It's going to spread to other parts of the body. If your patient has a melanoma, then we know that it is metastatic and it is going to spread to other parts of the body. So if we look over here, your top left, which one is that? That's your psoriasis, right? Okay. What's the middle top middle? That's going to be urticaria, right? So that's that's just like a itchy rash, nothing crazy. Top right, top right. That's going to be your eczema, right? Bottom left is herpes zoster. Middle bottom is acne, and then your far right on the bottom is vitiligo. Xerosis, once again, it's dry, itchy skin. Old people get dry, itchy skin. They dry up, right? How do we treat psoriasis? We talked about this in class. I'll give you a moment to think about it. Yes, glucocorticoids. Prednisone is going to be a big help for this type of problem. Next slide. Here you have your pressure ulcers. You have stage 1, 2, 3, 4, and a deep tissue injury. Stage 1 is not blanchable and it's going to stay red, okay? Stage 2, you're going to find a blister, just to keep it as simple as possible for you guys. Stage 3, you're going to see a blister, fat, slough, but it's not in the bone or muscle yet. Stage 4, we are at fat, muscle, bone, and slough. How would you prevent these injuries in your patient? We want to make sure that we keep them dry, keep their sheets wrinkle-free. We want to make sure that they have good nutrition, good circulation, right? Because decreased circulation to these places is going to increase their risk for this problem. We want to make sure that we support their contact points, so bony prominences. We want to make sure that we either put them under pillows or make sure they stay off of the bed, make sure we turn our patient Q2 hours, etc. You guys know this stuff. If you don't, please go back to your 5th semester portion when you guys talk about this. I believe it's in mobility, but just touch on that a little bit. Now, you have this up in the right-hand corner. What problem is this? How would you stage this pressure ulcer? It is a deep tissue injury, okay? Deep tissue injury, not a stage 4. It's like a very bad blood blister. These can take weeks to months to get rid of, all right? Last but not least, let's talk about cellulitis. You guys have heard of it. You guys are probably familiar with it in one way or another, but let's kind of just touch on it. What is it? It's a systemic infection, and we need IV antibiotics to fix it. It's painful, it's red, it's swollen, and it's warm to touch. Is it possible to get cellulitis and a clot, a DVT, mixed up based on the signs and symptoms? Absolutely. Is it possible that this patient on the right, see this patient here, how do you treat cellulitis? Is it possible that this patient got this from a little bug bite? Yes. So cellulitis, generally, your patient will come in, they'll say that they had a bug bite or something irritated their leg, and they're not sure what it was. And usually you can see kind of generally where it started. And you see the line on the patient is indicating that it's getting better. If the redness was growing, then we would have an issue. This patient is probably on IV cephalosporin drugs or like doxycycline We want to make sure that this leg is elevated. You can see the pillow on it. We want to make sure that it is not dangling or hanging. If they're sitting down, they should try to elevate it because we need all of that fluid to go back to the heart. And by doing that, you keep the leg above the heart. We want them to mobilize. If they mobilize, what's that going to do? That's right. It's going to help move everything around. Do we want compression on this leg? Does that leg look like it needs compression? I really hope you guys said no, because that is correct. No compression. Do we want heat or cold on this wound? No. Elevate, mobilize, increase circulation to increase healing. Okay. I hope this worked, guys. Hope you enjoyed the presentation. Please reach out if you have any questions. Thank you.